Good evening and happy Sunday. We're waiting on everybody else to come in. Hope you guys are having a lovely weekend. We're just another minute before we start. All right, we're going to get started. So it's like July is actually Fibroid Awareness Month. So I'm going to be doing a series of talks about uterine fibroids. I'm Dr. Obi Nawobi. I'm a board certified vascular surgeon and founder of Vein Health Clinic's Vascular Health Center here in Central Florida. I want to talk about understanding fibroids, your non-surgical options, and everything your doctor should have told you about UFE, which is uterine fibroid embolization. This is a statistic that started this webinar. Only 3.5% of women with fibroids receive a UFE. So where the other 96.5% go? Well, 73% receive a hysterectomy, which means the uterus is removed. 23% get a myomectomy, both major surgery. And only 3.5% of women in the United States are offered a uterine fibroid embolization, which is a 45-minute procedure. Tonight, that changes for everyone in this room. So what you're going to learn tonight, we're going to do a 60-minute roadmap. What are uterine fibroids? The 7 symptoms most women ignore. All 3 treatment options, we're going to go over honest pros and cons. We're going to go to get a deep dive into what UFE is, talk about insurance, what do they pay for it, and then we're going to do a live question and answer session. So this webinar is for you, and you can check the box. If you have 3 or more of this, I want you to keep watching. If your periods are so heavy, you go through a pad or tampon every hour, or you have to put on extra pads. If you have pelvic pressure, heaviness, or fullness in your lower belly, if you frequent the bathrooms multiple times because the fibroid is present in your bladder, if you have a bloated belly, like you look like you're pregnant, if you have painful sex or very painful periods that last longer than 7 days, unexplained back or leg pain, and then constant fatigue after your menstrual, and then you've been told surgery is the only option. If you have up to 3 of this, I just want you to just list the number that you have in the chat. List the number you have in the chat out of all these, whether it's 1, 2, or 3. You can list the number on the chat. So if you're coming in, I just went over what we're going through today, and I went through the symptoms. So I'm Dr. Obi Nawobi. I trained in Tennessee for my medical school. I then went to New Jersey to do general surgery fellowship, and then went to Albany Medical to do a vascular fellowship. Also got a master's of public health at Hopkins. I'm board certified in vascular surgery, and I'm an expert in minimally invasive treatment. And what I always say is that every woman with fibroids deserves to know all her options before she decides on what to do. So what are fibroids? Well, these are the basics. The good news is that it's non-cancerous. So fibroids are non-cancerous growth that develop in all the walls of the uterus. They are made of smooth muscle and connective tissue. So it's not a cancer, it's benign in almost 100% of the cases. One or many fibroids is called fibromatosis. Most commonly, it occurs between the ages of 30 and 50, and it can often shrink after menopause. So they range in size from a little seed to as large as a grapefruit or even a cantaloupe or watermelon. They grow in response to estrogen and progesterone, and sometimes they can cause no symptoms. They're very, very common, and they are treatable, so you have options. So how common are fibroids? They are more common than breast cancer, diabetes, or asthma in women of reproductive age. In fact, 70% of all women develop fibroids by age 50, while you have 80% of Black women that develop fibroids by age 50, which is about 26 million people in the US currently living with fibroids. Most women are diagnosed late after years of symptoms, which are dismissed as normal periods. And fibroids are the number one reason for hysterectomy in the United States. And 62% of women have never heard of uterine fibroid embolization. And that ends tonight. So there are different types of fibroids, and they can grow. It depends on where they grow on your uterus. If it's intramural, which is the most common, if it grows within the uterine wall, it causes really heavy periods, pelvic pain, bloating, and an enlarged uterus. It's submucosal when it grows beneath the inner uterine lining, and it causes heaviest bleeding and most impact on fertility if it's submucosal. And it's subserosal. This leads to pressure symptoms. It grows on the outer uterine wall. It causes pelvic or back and pressure pain and urinary frequency. The size matters. Size matters, but it's interesting. If it's small, it could still cause a lot of damage. But the size of the fibroid matters. It can start from a grape, which may be symptom-free, and you may not know you have it. Then it goes to a lemon. Then your symptoms you start having heavier periods and some mild pressure. Then it grows to an orange. You have significant symptoms, bloating, frequent urination. And then it grows through a grapefruit. That's when you have severe symptoms. You have a visible enlarged belly. Your belly is bigger. Or when it's a cantaloupe or big watermelon, then this way it can displace your organs, and a procedure is often recommended. So UFE can shrink fibroids by up to 83% in size, regardless of the starting size. And multiple fibroids can be treated in a single procedure with UFE. 7 symptoms you might be ignoring. So these are 7 symptoms. 1, periods are so heavy that you go through a pad or tampon every hour. 2, you have pelvic fullness in your lower belly. 3, frequent bathroom trips because it's pressing on your bladder. 4, you have a bloated belly. People ask when you're due. 5 is painful sex or periods lasting 7 to 10 days. 6 is back or leg pain because fibroids could be pressing your nerves. And 7 is persistent fatigue from chronic iron deficiency. So which symptom brought you here to tonight? Put in the chat whether it's a 1 or true 7. Or if you have 3 or more, just keep that in mind. So I'm just going to do a 3-minute look, like a video break on what the procedure entails. What does the fibroid procedure entail? Let's look at that with a little short video here. So I'm just going to play a quick video.
Uterine artery embolization is a modern, minimally invasive treatment for uterine fibroids, especially when surgery is not recommended or when the patient wants to preserve the uterus. The procedure is indicated for symptomatic fibroids causing heavy menstrual bleeding, chronic pelvic pain, pressure on the bladder or bowel, or rapid uterine enlargement. Under local anesthesia, the femoral or radial artery is punctured and an introducer is placed. A diagnostic catheter is advanced through the introducer into the common iliac artery and then into the internal iliac artery. Using digital subtraction angiography, a catheter is guided into the uterine artery. Embolization particles are slowly injected through the microcatheter. These particles occlude the lumens of small arterioles, inducing ischemia of the uterine fibroid while preserving blood flow to the myometrium. The catheters and introducer are then removed. Within 3 to 6 months, myomatous nodes decrease in volume by an average of 40 to 60%. Menstrual cycles normalize, while pain and the sensation of pressure subside.
That's it. Very quick view, and we're going to go into more detail. So how does fibroid affect your daily life? Well, at work, women with fibroid miss an average of 3 to 4 days of work per month due to symptoms. That's about $34 billion of U.S. productivity loss. Family, well, pain during sex strains relationships. Fertility challenges create emotional burden. A lot of times you can't get pregnant if you have subserosal fibroids blocking implantation. So you have a lot of years lost for families delaying to start a family because of that. Mental health, well, if you're in chronic pain, you're tired all the time, this could lead to anxiety and depression because you don't know how to plan your days, because you don't want to bleed too much. So it could affect your mental health. Women on average wait 3.5 years from the symptom onset to diagnosis. They're told it's just a heavy period, try birth control, you'll feel better after menopause. But who wants to wait 15 years to feel better? No. This is one thing that is dear to my heart because there's a big racial health disparity with fibroids. The data on fibroids and Black women is stark and it's also actionable. 80% of Black women have fibroids by age 50. So everybody here knows somebody that's got fibroids. And they're 3 times more likely to have severe symptoms and 2 times more likely to be offered a hysterectomy first. 30-year-old Black woman, hysterectomy. 32-year-old Black woman, hysterectomy. 40-year-old, hysterectomy. There's no concern. They just offer you a hysterectomy. Why the disparity exists? Well, a lot of people think it's genetic factors. There's specific gene variants more prevalent in women of African ancestry. Vitamin D deficiency, chronic in Black women. The vitamin D suppresses fibroid growth. So even if just go check your vitamins D levels, if it's just a simple tablet, start taking vitamin D today. Go get it from Walmart. Chronic psychological stress increases inflammatory response. A systematic bias in referral patterns historically under-referred for minimally invasive procedures. They just offer them hysterectomy, offer everybody hysterectomy. And then fewer interventional specialists in Black communities, so then they don't have the access. So I want every woman in Central Florida, especially Black women, to know you have options. You don't have to lose your uterus. How are fibroids diagnosed? Well, there are 4 tools used all together. It gives us a good picture. Number 1 is the pelvic ultrasound. Everybody knows this from getting an ultrasound during pregnancy. It's non-invasive. It identifies fibroids, their size, their location, and most commonly done transvaginally. If you're over 40, though, the pelvic ultrasound may not be very accurate. So we recommend an MRI, and it's the gold standard because it shows us everything: the number of fibroids, whether you have an associated problem called adenomyosis, how vascular they are, and it enables us to plan the exact type of evaluation and procedure we need to perform. There are other modalities like hysteroscopy, but that's not necessarily needed, or sonohysteroscopy is not necessarily needed as well. So take a breath. Here's what you want to know. You're not alone. 70 to 80% of women develop fibroids by age 50. That's 26 million women have fibroids right now. Your symptoms are real. Heavy pressure, pelvic pressure, fatigue. These are treatable. And the diagnosis is clear. Either an ultrasound or MRI is the starting point. So 3 treatment options. We're going to go over the exact treatment options, what you need to do exactly today. Know everything. You're going to know everything about fibroids by the time we're done. I'm going to go over everything, honestly. So what are your treatment options? Let's give you an honest breakdown of all the treatment options. There are 3 main fibroid treatments at a glance. 1 is hysterectomy. That's the traditional method. Traditional surgery, the surgical is just the removal of the entire uterus. It's permanent. No more periods, no future pregnancies. This is done under general anesthesia. It's a hospital stay of 2 to 3 days. The recovery is usually about 8 weeks. Number 2 is a myomectomy. This is fertility preserving. It's a surgical removal of the fibroid. It removes the fibroids but keeps the uterus. You can have 10 to 20 fibroids removed. The fertility is still possible, but the fibroids can grow back. And that's the 50% of the time they grow back within 2 years. It's done under general anesthesia. It's a 1 or 2 day hospital stay. Recovery is about 6 weeks. The third procedure, which is minimally invasive, which is what we're advocating tonight, is a uterine fibroid embolization, which we block the blood supply to the fibroids. There's no incision. Your uterus and fertility are preserved. Moderate sedation, home the same day, and your recovery is about a week, usually 3 to 5 days. And we're going to go deeper into all of them. So hysterectomy is the complete removal of the uterus. We already talked about that. Sometimes they say, I'm sorry, we had to take out the ovaries because it was stuck. Yes. So sometimes you get a hysterectomy, but you also get a oophorectomy, which means you're in menopause already, no matter how old you are. This totally eliminates the fibroid, but it also eliminates the uterus permanently. So the pros is that it's a permanent relief. The fibroids cannot grow back. It eliminates all fibroid symptoms, definitely. There are no periods after surgery. And it may be best for if there's a cancer concern. So if you've not had a pap smear, usually it's good to have a pap smear if you're over 40 to check whether you have a cancer. If there's a concern for cancer, it's the best option. The cons that is major surgery. So you're getting general anesthesia in a hospital 2 to 3 days. Your recovery is about 8 weeks. If it's done laparoscopy, you can recover in 4 weeks. And then it's permanent infertility. You can't get pregnant without a uterus. The risk of early menopause, yes. I've heard this all the time. Because the ovaries are mistakenly removed, you go into complete menopause at 40 or at 35. And there are surgical complications. Some people have an infection problem they have to deal with, go back to the hospital for infection. They could damage your organs, and they are bleeding risk. Hysterectomy, let's look at the numbers. There are about 600,000 hysterectomies performed in the United States, and 73% of them are for fibroid patients. Recovery is 6 to 8 weeks. Most hysterectomies are for fibroids, just for the benign cause. It's not for any other thing but just fibroids. It's very invasive, and so we all know that, and it does not preserve the uterus, okay? Let's talk about myomectomy. This is surgical removal of the uterus. They try to pluck out the fibroids one at a time. Sometimes they can't get to all of them. There are different approaches. They could cut you open. They could use a laparoscope, which is using the pinholes to do that. The pros are that the uterus is preserved, fertility is maintained, it removes fibroids directly. It can also be laparoscopic. It's very good for large intramural and submucosal fibroids. Very difficult to do subserosal with it. The cons is that the fibroids could just grow back, which is about 30% chance in 2 to 5 years. General anesthesia is required. Recovery is about 6 weeks, a month to 6 weeks, even if it's done laparoscopically. And you can get scarring that may affect your fertility long term. It's not very practical if you have 20 fibroids. It's very difficult to get all of them out, so you still have some left. And lastly, uterine fibroid embolization. Well, this is an image-guided, minimally invasive procedure performed by a vascular specialist that blocks the blood supply to the fibroid and causes them to shrink. It's done with a tiny puncture, usually in your wrist. It's the same day procedure. It takes about 45 minutes, moderate sedation, and your recovery is usually 3 to 4 days. If you want to take a week off, that's good. It reduces the size of the fibroid, causes them to involute completely, so your symptoms go away, and it has a 90 to 95% patient satisfaction. So who performs UFE? This is why it matters. UFE is not performed by an OBGYN. So they're not going to offer that to you. It's performed by a vascular surgeon or interventional radiologist who are especially trained in image-guided procedures inside blood vessels. So after 5 years of general surgery, I had to do another 2 years of blood vessel study. So that's 7 years in becoming an expert in this, while OBGYNs trained for 4 years in just taking out the uterus or removing them, plucking them out. So we're completely different specialty. I'm trained in catheter-based procedures. We have extensive experience in interventional procedures. We do this in a state-of-the-art imaging suite. We have 5 locations here in Central Florida. There's no OBGYN referral needed. You can just call directly to get it done. No referral is needed. So this is a 3.5% problem. Only 3.5% of women are receiving UFEs, and there are 5 reasons, and none of them are medical. The first one is most OBGYNs, they don't perform UFE, so they don't bring it up. Just do things that they just want you to do things that they can perform, which is either myomectomy or hysterectomy. The referral patterns favor surgical colleagues. That means they'll rather just stick around what they can do. UFE is relatively new. It's been around for about 25 years, so it's not like an experiment. It's been around for a long time. There are thousands of people that have done it. We're doing between 50 women a month in all our locations. There's just a lack of awareness in communities that need it most, mostly Black, brown communities. And some physicians incorrectly believe UFE affects fertility, but that was 25 years ago, not currently. and about 60% of women have never heard of UFEs at all. They just don't know anything about it. So that's very, very important. All right, so let's keep going. So this is just a nice summary. You can take a screenshot of this, of everything that I just spoke about hysterectomy, myomectomy, and UFE. Just a nice summary. One thing I forgot to add, insurance covers all of it. So insurance covers a hysterectomy, they cover a myomectomy, they cover UFE, even Medicaid or Medicare or TRICARE. So let's talk about the myth versus the facts. The myth is that hysterectomy is the only real cure for fibroid. That's a myth. It's not true. UFE means you can't have children after UFE. Not true. The fact is that UFE achieves a comparable long-term symptom relief in most women without removing your uterus. So if you get a UFE, it's the same as getting a myomectomy. The only thing is that it has a less chance of the fibroids growing back. The fact is that many women have healthy pregnancies after UFE. But if fertility is your top priority, we have to have a personal discussion about that. The question every woman should ask is that before we discuss surgery, am I a candidate for UFE? Most doctors who don't perform UFE would not bring it up. It's not malicious. They're just in their silo. This is what we do. This is how we can help you. But they don't raise that issue about UFE. If your doctor says yes, there's an option, just call us and we'll take care of it. If your doctor says no, ask why. Why is the UFE not an option for me? So let's go over the UFE procedure in exact detail, no surprise, and we're just going to go over exactly what happens step by step. So the first step is a consult and imaging with MRI. Like I said, if you're over 40, you do an MRI. If you're under 40, you get an ultrasound. The MRI will confirm the fibroid location, the size, and the blood supply, and review your case personally. The second is arrival or prep. You arrive at outpatient center, we'll put an IV, you get some moderate sedation to relax you, and then we start. The procedure is done in just 3 steps. The first step is access. A small IV is put in your wrist. That's it. So that's the only, I'll say, painful part, quote unquote. The second step is positioning, where we use radiology guidance to guide a catheter, a long spaghetti catheter, all the way down into your uterine artery. When we get to your uterine artery, the third step is embolization. So it's APE, 8. Embolization, where we inject biodegradable tiny beads that go in, is the size of a grain, that are injected and they block the blood supply of the fibroids. That's it. The procedure is complete in 45 minutes. You rest for about 30 minutes and you go home. That's it. Same day, same team, same doctor. Very straightforward. We're going to play a short video about UFE quickly.
This video has been produced to familiarize you with the uterine fibroid embolization procedure, UFE. UFE is a safe, effective treatment for fibroids that has been performed for nearly 20 years. It is one of several treatments that may be used to treat fibroids in the uterus. Uterine fibroids are non-cancerous growths that develop from normal uterine muscle cells. There are 4 types of fibroids that develop in or just outside of the uterus. Submucosal fibroids grow into the uterine cavity. Intramural fibroids grow within the wall of the uterus, and subserosal fibroids develop on the outside of the uterus. Pedunculated uterine fibroids occur when a fibroid tumor grows on a stalk, resulting in pedunculated submucosal or subserosal fibroids. All fibroids require a supply of blood to survive and grow. UFE takes advantage of this fact to target the fibroids. Uterine fibroid embolization is a minimally invasive procedure. UFE does not remove the uterus or the ovaries. A small incision is made in the leg to gain access to the femoral artery. A long flexible tube called a catheter is then inserted into the femoral artery. It is guided up the femoral artery and into the artery that supplies blood to the uterus, called the uterine artery. The catheter is then guided to smaller arteries that supply blood to the fibroids. Uterine fibroid embolization delivers tiny microspheres to the artery that supplies the fibroids. cutting off the blood flow, causing the fibroids to shrink. The tiny microspheres are injected through the catheter and travel through the blood vessel. Since the microspheres are more than 60 times larger than red blood cells, they plug the tiny vessels that red blood cells travel through to feed the fibroid. The procedure is repeated in the uterine artery on the other side to make sure that all blood supply to the fibroids has been cut off. All fibroids are treated simultaneously. Once the blood supply to the fibroids has been blocked, the fibroids begin to shrink. There is no scar tissue and minimal blood loss with UFE. Recurrence of the fibroids with uterine fibroid embolization is rare. Most women are able to return to light activity within a few days of the UFE treatment and are usually back to work and normal activity, on average, within 11 days. Take back your life today.
So that was a short video. So let's talk about a little bit about the science of the microspheres. So the microspheres are tiny synthetic beads. Like I said, they are biodegradable. It's FDA approved for the last 25 years. They are 500 to 700 microns. And how they work, they're injected through the catheter in the uterine arteries that feed the fibroids, and they physically block the fibroid arteries. They are too small to block the uterine artery, so the uterus doesn't get damaged. But they go in and they block the fibroid arteries. That's why the fibroids shrink, and it starves them of oxygen and nutrients. So they shrink and die off. So what happens to the fibroids? Well, without blood supply, the fibroid cells die off, they infarct. Over 3 to 6 months, they then shrink, which you get about 50 to 83% fibroid reduction. Even if the fibroids are cantaloupe size or watermelon size, they just involute all the way. They are very, very safe. We've done thousands of procedures on many women, and it's very safe. Not a single bad outcome from even one patient. The uterine arteries have redundant blood supply, so the uterus is never damaged, and only the blood supply to the fibroid is permanently blocked. So what do we expect from the procedure day? The entire joint, let's talk about it. It takes about 4 hours. You arrive at the outpatient clinic, you bring a driver because we're gonna sedate you. You'll go home the same day. You're prepped with an IV, moderate sedation is given to you. There's no general anesthesia. Procedure is performed by me, 45 minutes. You recover for about another 30 minutes, and then you go home. That's it. Just bring comfortable clothing, a driver, and your questions. Back to life in 1 week. 1 week. So let's talk about the recovery timeline. Day 1 and 2, you're resting. The key thing with uterine fibroid, the key is that because of the uterine infarction that occurs, you're going to have pretty severe pain. But we give you an entire regimen to help you get through that period after the procedure is done. So your cramping will subside. Usually we give you a fentanyl patch because sometimes you have nausea as well. So the fentanyl patch is released, the patch that releases fentanyl slowly on your body. So even if you have nausea, you'll still have the patch working for you. We give you an anti-inflammatory agent, naproxen as well. And then we also give you a muscle relaxant, so to keep the uterus from getting cramping. So after day 4, your cramps have subsided. You can go back to light work. A lot of people go back to work day 5 to 7 usually. So you usually take 3 to 4 days off. And by the first week, second week, your life is back to normal. You do a follow-up imaging in about 3 months, and we do see the fibroids shrink, and it's a lot 6 times faster than the recovery of any surgery, any myomectomy or hysterectomy. So UFE recovery, we just spoke about it. It's fairly straightforward. The key thing is the post-embolization syndrome. That's the key, I would say, side effect of UFE. Is if you're researching UFE, you may have seen this term and gotten scared, but I'm going to explain it. This is like flu-like symptoms that occur 48 hours after the procedure. And it's a low-grade fever, fatigue, nausea, and cramping that occur after the embolization. That means that the procedure is working. If you're cramping and you have pain after the procedure, it's good news because the immune system is responsive to the fibroid tissue dying off and the body is breaking down the fibroid. So it creates a very severe inflammatory response. That's why we give you the naproxen, anti-inflammatory agent, the muscle relaxant, and the fentanyl. So we prescribe you an entire regimen that you have to take, especially the naproxen round the clock so that you can help with the inflammatory response. So it's fibroid pain, it's UFE painful? No. So it's not painful during the procedure, okay? It's not. But the cramping is common, like I said, afterwards. And after day 2 to 4, the discomfort significantly decreases, and most describe it as you can just take a over-the-counter medication for it. So UFE and fertility. Let's have an honest conversation about this, because that's where a lot of people throw that curveball. Most commonly we receive this question, and it deserves a complete honest answer. The good news is that your uterus is preserved. You keep your uterus. Many women have had successful pregnancies after UFE, including women I've treated. UFE is often preferred over myomectomy for women with multiple fibroids and avoids the surgical scarring. For women not planning future pregnancy, UFE is an excellent option because you just get the UFE done and you don't have to have surgery. Important, if UFE may not be the first line treatment if you're like 25 to 35 and you have one big fibroid, just one. If you have one fibroid, it might as well just get a myomectomy because there's one, they take it out, it could come back within 2-3 years, but it's just one of it, and you just get it taken out. If you have more than one, for women's like 25, 35, and you want to get pregnant within the same year, I'll recommend just getting a myomectomy. If you have like 15 to 20 fibroids, 5 fibroids, more than one, UFE is better because it can get to all of it. Because if you do a myomectomy, after like 2-3 months, you start bleeding again. And it's because they couldn't get to all of it. A lot of times they can't because there's so many. If it's just one, then they usually can get to it. So if fertility is a primary concern, that's what I'll lean to. What are the long-term results of UFE? Well, 83% you have shrinkage within 6 months, 90% satisfaction, and sustained satisfaction for most women out 5 years and beyond. Insurance coverage. Well, like I said, this is covered by every insurance plan, including Medicaid. So you don't have to worry about insurance coverage. So the top 6 questions before UFE. Will it hurt? No, it doesn't hurt. Can you drive home? No, you need to bring a driver. Does it affect fertility? It could. It could affect fertility, but the risk is individual, and it depends on the type of UFE. And in some cases, UFE is your only option if you have a fertility issue. And I can speak more about that personally with anybody. So let's talk about some patient results. I'm going to have some patients eventually log in at this point, but they just sent, these are some of the results that we've had. This is a woman that came to us. She said she used to change her sheets in the middle of the night. Her periods were so heavy, and she chose UFE. She was back home by 4 the same day, and she texted me. She actually drove herself to get groceries at day 5. The fibroid shrank 70%. Her periods completely normalized for the first time in 6 years. And she actually cried during her follow-up appointment because she didn't know it was possible to get. She wanted to take off work to have surgery. So she didn't know it was possible, and she was just back to normal. This is another lady, said she was really, really tired. Her hemoglobin went down to 7.2, and she was very anemic. She had 3 different doctors over 18 months, and nobody could figure out why she was anemic. On the scan, she had 4 fibroids. The heaviest blood loss she had seen was draining her. We did a UFE, and she just got herself back to normal. So what are your next steps? Well, in Central Florida, we have 5 locations. I'm a board-certified vascular surgeon. Like I said, we have state-of-the-art imaging. We do insurance verification. We have your UFE coordinator coordinate your entire care. These are our locations. here. We have in the Southwest. We have in Ocala. We got in Winter Garden, Oviedo, and in Winter Haven. So different locations for everybody. Well, let's go straight to questions here. Anybody, if you have any questions, go ahead and type it in the chat. Questions, type it in the chat. I will answer any questions. Anybody have any specific questions? Just type it in the chat for me. I can answer any question for you. Yes, it's vitamin D3 for the vitamins. Yes, it's covered by all insurance plans. It is covered by all insurance plans. I'm going to type my email in the chat. I'm available for another hour. If you want to do a quick teleconsult over the phone today, I can get that done with you. Just send me your number to call you, and I'll call you on your phone. So I'm putting my email in the chat. I'm available for a free teleconsult. Just send me an email with your number. Yes, we do take Oscar insurance. That's not a problem. Yes, we do take Oscar insurance, and we've had many patients. We've treated many patients. Probably every month we treat about 4 or 5 Oscar patients. No, I'm not saying the first thing I said regarding regarding the best procedure. If you are over 40, we do an MRI. A lot of times, there's something else that could be impacting your pregnancy called adenomyosis. The only treatment for adenomyosis is a UFE. So if you have adenomyosis, then UFE is the best option for you. So even if you're over 40, you can still get a UFE. People that have had difficulty getting pregnant, is the most common reason is because they have both a subserosal fibroid, which is difficult to reach with a myomectomy, and adenomyosis. So it's very complex. It's usually it's on a one-on-one basis we decide the best option. It's not that straightforward. We have to look at your anatomy with the MRI and then give you the best option. If you have just 1 fibroid, 2 fibroids, and they are where it could be reached with surgery easily, then we'll say go ahead and get the surgery. If you have many fibroids, it's better to get a UFE. If it's subserosal all the way, it's better to get a UFE because the surgery is hard to get there. So they're not going to get it. So these are the options. Is we have to look at it on a one-on-one basis. The MRI, though, shows everything. So that's why people say get ultrasound. If you're over 40, you want to get an MRI because it really shows everything. After the MRI, we can make the best decision. Yes, so at 42, we'll recommend getting an MRI. And with the MRI, we'll be able to see everything and give you the best option. But if you've already had an ultrasound and it showed you had multiple fibroids, UFE is better. The questions are good. Keep the questions coming. You can ask me anything. I'm right here for you. It's Uterine Fibroid Awareness Month, the month of July. We're making people aware. You have to let people know. tell your friends, tell your family. We're going to have more sessions like this. We want to have over 100 people, more than 100. Get the word out. Let people get the care they need, the care they deserve, instead of everybody getting their uterus removed completely. I mean, I know that's what my mom had like 30 years ago, but not in 2026. There are options. Keep the questions coming. Any other questions? So I've left my number. I'm sorry, my email. Send me an email if you want to have a consultation this evening. I will call you and we can do a quick one-on-one consultation to protect your privacy. You can book directly on the website as well, or you can just call the office with the location there is nearest to you to schedule an appointment, and we'll get you in same week. You don't have to wait weeks to be seen. Any other questions? Okay, we'll give it another minute or so, and then we'll end the webinar for today. I want to offer you to, you're going to maybe get in some more information about this. We'll send you, you'll be getting a text or email with the next meeting. Just send it to everybody you know. Send it to everybody you know. Give a gift of fibroid health this month. Make sure everybody on this line today may become an advocate. It's July, it's Fibroid Awareness Month. There's awareness month for everything, but this is a significant problem. So I want you to, when you get the email, send it to everybody you know, every woman you know. It's like 4 out of 5 women have fibroids. So it's so common. Everybody you know, every 5 people you know, 4 of them have the same problem. They may not tell you, but they're dealing with the same issue. Send it to them, just via email, forward it, and you never know, they may be dealing with this situation. You could save somebody. All right, I think that's it. I'm so happy that everybody could attend this. I hope you got some information that was helpful. I hope you were educated, and God bless. I'll see you next time. And if you want to have a private discussion with me, send me an email. I'll call you on the phone. We can talk about it this evening. There's no waiting. Okay? Take care. Bye.